Hi, my name is Amanda He, and I spent the summer studying cost and utilization of the dual-eligible population under Dr. Kate Bundorf and Dr. Bristana Kaufman. To provide some necessary background, dual-eligible beneficiaries are a highly vulnerable group of those that qualify for both Medicare and Medicaid programs. They may qualify for Medicare on the basis of age, of being 65 or older, or as a long-term disabled adult, and then further gain state Medicaid benefits due to their low income status. These individuals are more likely to suffer from multiple chronic conditions, cognitive disabilities, and functional limitations, in addition to being at a higher risk of homelessness or food insecurity as a result of their low income status. Due to their complex needs, dual-eligible beneficiaries utilize a large range of services, including inpatient care, post-acute care, and long-term services and supports, consequently making them a high-cost population. As you can see in Figure 1, dual-eligible population beneficiaries make up a disproportionately large share of both Medicare and Medicaid spending. Although Medicare and Medicaid both play a large role financially in financing care for duals, they are ultimately separate entities that have little incentive to coordinate care and reduce costs for the other program. Thus, state and federal governments have worked to enact integrated care policies that utilize capitated value-based payment models in order to coordinate care and payment models between the two entities. And a lot of these policies are still being developed today. I sought to examine existing evidence on spending trends, cost, service utilization of dual-eligible beneficiaries in this study in order to inform integration strategies for both North Carolina and the US as a whole. This was done through a targeted literature review through notable databases, including PubMed and Health Affairs, as well as a careful analysis of data from reports such as MACPAC, MedPAC, and the North Carolina Department of Health and Human Services. The team also conducted a multi-stakeholder listening session to gain perspectives on the very nuanced discussion on how to best integrate care for duals. Looking at Figure 2 here in the center, I found that of the 26 dual spending-based studies, there were only 7 studies published within the past 5 years with complete Medicare and Medicaid data. This means we have a very limited understanding of the full picture of duals in terms of their health service uses, spending, and other care needs. Additionally, most of the studies evaluated general spending trends and specific high-cost subpopulations, with very few including racial considerations of dual spending or other need-based subgroups. Among the information gathered on spending of duals, however, we found that around 1/5 of duals accounts for about 3/5 of combined Medicare and Medicaid spending. So a small portion of duals accounts for a very large percentage of spending for both programs, although fewer than 1% was in the top 10% of costs for both Medicare and Medicaid. We also found that although duals tended to be high cost relative to Medicare-only beneficiaries, their spending growth trends found to match similarly to Medicare-only beneficiaries. In the most recent years, the dual spending was more concentrated in post-acute services and long-term care. In terms of characterizing the high-cost subpopulations, we found that the high-cost duals were incredibly diverse in terms of age, race, care setting, and healthcare needs, as well as other services that they used, as shown in Figure 3. So if you look here at the graph, for instance, although around 50% of duals age 80% were deemed as high cost for Medicaid, and around 22% were deemed as high cost for Medicare, there were still around 20% of duals that were found in the bottom half of both Medicare and Medicaid spending. This just shows that there's a diversity in the demographics and characterization of duals, and we can't make general sweeping conclusions based on who they are. And thus, they require more targeted and very specific healthcare needs targeted to their specific healthcare plans targeted to their specific needs. Studies identified duals utilizing long-term care services and supports and those with multiple chronic conditions as the most likely high-cost subpopulation groups, although this is not, like I said, a very full picture of what duals need. As you can see by the diversity and complexity of the dual-eligible population, we require more integrated data care systems with complete Medicare and Medicaid linked data in order to understand the full picture of duals, healthcare uses, and needs. This is crucial because many health systems are transitioning from a fee-for-service model to a value-based care model, which creates more incentives to improve care for high-cost patients like duals. Furthermore, we need more evidence evaluating duals not only based on cost, but also based on their care needs. All of this work is to support a community-centered whole person care model that is tailored to the diverse needs of each beneficiary, especially in states like North Carolina that is currently shifting to a managed care model. That transitions really well to our ongoing work as we are currently analyzing North Carolina dual-eligible beneficiaries on spending and service utilization using need-based subgroups. These need-based subgroups are divided based on shared care needs. So if you see at the little bubbles there, nursing home residents, long-term services and supports users, community well users, innovations, waiver users, intensive behavioral health users, CAP-DA users, and more are considered part of these need-based subgroups. Our preliminary findings show that Medicare and Medicaid have around an evenly split in carrying the spending burden of duals, suggesting that there are opportunities to improve care through integrated payment and care models for North Carolina dual-eligible beneficiaries. I'd like to acknowledge Dr. Amy Clark, Aparna Higgins, and Lucas Stewart for their guidance and support on this project, as well as Arnold Ventures for supporting and funding the ongoing work. Thank you all for listening.